So shall we start?
Please, please.
So thank you very much again for inviting me for the follow-up session of the previous session. So I am Saima Ahmad, again, interventional neuroradiologist in Lahore General Hospital. And today is the follow-up session of the previous session, which was vascular anatomy and the intracranial aneurysms. It's a part 2. So the brief outline, I'll be talking about only about the projections and only about the segments of ICA and the aneurysms according to the segmental classification of the ICA. Because in the last session, there was, some queries about the projections, and so we talk in detail about the projections here. So before I talk about the projections, I tell you something about the standard skull views. As far as youngsters are concerned or PGRs are concerned who are new one in the field, for them it is very difficult to understand that which view is AP view, which is lateral view, and which is oblique projection. So always with the digital subtraction angiogram, which is the conventional one, a scout film is always available there. So we always compare it with a scout view, and then we tell about the different type of the projection. So these are the standard skull views which we use. The first is for the first A and B. These are the AP projections, and you can see my. These are the for conventional internal carotid artery. These are the AP projections. So all of the skull views, we use two landmarks. The one is the Petrous ridges, and the other is the orbital margin. So we move the tube or incline the tube in the different angles, keeping these two landmarks. So this is conventional AP view, both for the internal carotid artery. In this, you can see that the Petrous ridges are at the superior orbital margin. And this is another view in which it is Petrous is at the inferior orbital margin. You can see both orbits. So these are the AP projections. So one clue which is not written anywhere in the book is this for the youngsters is this, that they can evaluate by looking at the orbits. When we see two orbits in the frontal projection, meaning thereby this is the AP one. So the next, these are the few other projections. This is the Caldwell projection, and this is the Townes view. Townes view we typically use for posterior circulation, and you can see that the tube is inclined at the 30 to 45 angle, and foramen magnum is there. And this is just to look at the posterior cerebral arteries. And this is another view, which is the oblique view, in which the Petrous ridges are again at the lower 1/3 of the orbital margins, and this is for the supratentorial vascular structures. This is segmental view, and this is extreme view, which is to see the ACOM or to see the bifurcation of the middle cerebral artery. Sorry.
Dr. Saima, what is the submental में कितना difference होता है angle का?
सर इतना ज्यादा डिफरेंस नहीं होता. सबमेंटल जो होता है वो 30 to 45 के दरमियान ही इनका डिफरेंस होता है, लेकिन इसके अंदर एक पीछे से एंगुलेट करके आप इंटेंसिफायर को बिल्कुल उसकी चिन के ऊपर ले आते हैं.
अच्छा तो व्हाट इज में भी लगभग हमें यही कुछ नजर आएगा, राइट?
जी.
अच्छा, ठीक.
This is the lateral view. Lateral view is उसके अंदर you have to अलाइन द इंटीरियर क्रेनियल फोसा, दोनों एक साइड के ऊपर अलाइन आप कर देंगे. अगर आपने इफ यू वांट टू सी द वर्टिब्रल आर्टरी लैटरल व्यू, उसके अंदर यू नीड टू मैग्नीफाई इट. फर्दर व्यूज कैन आल्सो बी सीन, बट दीज आर द स्टैंडर्ड व्यूज which we normally use. Normally we use AP and lateral, and we have to see the capillary, arterial capillary and the venous phases in two standard views. This is for the neurointerventional procedures. Peripheral intervention, you can use one plane. That's why we use both planes, because we have to see the AP and the lateral. So conventionally, we have to see the capillary, artery, and the venous phases. And the physiological perfusion time is about 3.5 seconds, and in which you can see the arterial, capillary, and the venous phase. But if the time is more than 7 seconds, meaning thereby there is some kind of the occlusion, because this is the time which is needed by the contrast to reach from the cavernous ICA to the first cortical vein, which is obviously on the venous phase. So we have to see these all phases. When we take the lateral projection, we wait till the venous phase comes. When we take the AP view, we wait till the venous has come, and we have to see and compare both AP and the lateral. So this is, now we start with the DSA. So this is anteroposterior internal carotid artery. This is a common view which we take for the internal carotid artery, and here you can see the Petrous ridges are inclined at the superior orbital margin, and you can see that both orbits. So for those, for newcomers, not for me, obviously, you can see that when both orbits are seen, and this is the scout film, this is the AP projection. So first arterial, then capillary, then venous. And the physiological circulation time is 3.5 seconds. So you have to see all three phases in one projection. This is typically for the internal carotid artery on both sides, right and the left. And this is lateral again.
So एक चीज रेजिडेंस के लिए बता दूं, आप लोग समझे the three phases Dr. Saima mentioned. So there is an arterial phase जो बीच में दिखाया हुआ है, फिर there is a capillary phase and there is a venous phase. ये remember all guys, these three phases, because if you want looking for AVM, you will see some venous channels in the arterial or in the capillary phase, and you know that there's a shunting. So these are the three phases which Dr. Saima has shown beautifully. जी डॉक्टर साहब चले आगे.
जी, इसमें एक और चीज भी है which I would like to mention here is this, कि when we talk about the frame rate also, when we are going to see the AVM, so we increase the frame rate. Normally the frame rate is 4 to 5 frames per second, but it is about like we can 20 frames per second के ऊपर भी चला जाता है when we want to see the AVM. So it's different. When you are suspecting something, then you modulate always your settings. So then lateral. For internal carotid artery, you take the AP projection and then the lateral projection again. And the lateral projection, this is the scout film again for those people who were like, we cannot understand which view is the lateral and which is the AP view. So this is the lateral view. And you can see that very beautifully, you can see the cavernous and ophthalmic. There are few ophthalmic artery can also always be visualized in the lateral projection. You cannot see very clearly in the AP projection. And then you can see the branches of the ACA and MCA always in the lateral. Again, in the lateral, you do arterial, capillary, and the venous. But here I didn't put all the three phases, but always and always the three phases. If you actually want to see the pathology or rule out the pathology. Because sometimes in the venous phase, there is a pathology which is only venous. For example, developmental venous anomaly. Or for example, there is a tumor like meningioma. Meningioma very, very rarely show the typical pictures. Sometimes they show blushing in the late venous phase. So always look at the venous phase. Now, this is another type of the view, which is oblique view. We do not take oblique view in the normal angiograms, but sometimes when we see the aneurysm and we want to enhance this and we want to magnify this thing, then we take the transorbital oblique internal carotid artery. So this can be magnified. This if you don't want to magnify it, it doesn't matter. But you see that this is the orbit. So it is showing this aneurysm is very, very clearly. So in the oblique, we do the angulation of the tube from 35 to 45. And from the skull view, you can easily identify that this is the oblique view. So you can do right oblique, you can do left oblique, depending upon the pathology which you want to see. So orbits, always identify the orbits and then define your projections. This is again a view, oblique view, but on the right side. The previous one was on the left side, because in the last session, there was a problem that how identify the left and the right side. So this is the right side and this is the left side. So you see the left side, it's going from here. And this is the left orbit. And then we see here, this is the right orbit.
So you just have to the residents just have to get used to that curve, just like you look at your finger or अगर मैं ऐसे कर दूं
Yeah.
दिखाऊं, you will find out
Because I was thinking that how I'm going to explain them that how they can identify the projection. So I think that they can see the orbits. This
right.
is very, I mean, this is very easy to identify the orbits. It's not written in the books, but I was thinking how I explain to them. This is easy. For oblique again, 45-degree right internal carotid artery. So we can incline the tube at any angle you want. If we can move it more, if you want to open the vessels. Sometimes you cannot see the aneurysm, then you ask them to make the angle more wide. You can make it wide. It depends upon the pathology you want to see. So this is for vertebral artery, lateral. So you have to take whole skull in this. And for the vertebral artery, always magnify in comparison to the internal carotid artery. And we have to include this part because we want to see the extradural pica. So the C1, it should always be within the film. So this is, one question. After this, I want to ask if somebody want to answer this, that which view is this? And because I told you that in which projection we want to see the posterior cerebral artery and it's the branches, and this is the same view.
Which one is good for posterior circulation basically?
Which one?
Guess मारे कोई फर्क नहीं पड़ता है, just it doesn't really matter. Anybody?
Okay, so Dr. Amar is commenting.
Yeah, he did. Anybody else? Any thoughts?
And
Anybody else?
Dr.
Don't be shy.
Peran want to share.
बोले जो भी है कोई फर्क नहीं पड़ता.
Right.
So posterior cerebral arteries को देखने के लिए we always do the Townes view. Townes के अंदर Petrous superior orbital उसके ऊपर और इसके अंदर पूरा आएगा, पीछे से lambdoid suture तक नजर आएगा. आपने इसको सारी यहाँ पे बोनी सुपर उसको खत्म कर दिया ताकि आपको पीसीए की सारी ब्रांचेस नजर आए.
So think about it like this कि यहाँ से अगर हम देखते यूं, है ना, अगर यूं देखते तो सारी बोन्स आ रही होती हैं और यहाँ पे posterior circulation है. So they went like this. This is the Townes view. अब इसमें ये सब चीजें है ना नजर आ रही है, ये सब चीजें नहीं है. अब it's going directly and looking at this circulation, right?
क्योंकि हमने बोन को हटाना होता है और आई वुड सजेस्ट कि if somebody goes to the DSA department और वहां जाके if you see the C-arms which is AP, which is lateral, and where is the tube and where is the intensifier, तो उससे बहुत ज्यादा जो है मतलब आप चीजें पिक करेंगे, आपको पता चलेगा ट्यूब किधर होती है, इंटेंसिफायर किधर होता है और कैसे आपने करना होता है. So this is another projection. I think this is according to the orbit one can identify कि ये क्या हो सकता है.
ये तो बड़ा आसान है, ये बता देंगे खटाखट. शाबाश, लिखते जाएं.
Anyone? It appears likely to transorbital oblique.
Yes, this is transorbital oblique, and we did the 45-degree inclination of the tube, and this is oblique, and you can see this orbit. इसकी oblique position से पता चल रहा है. So next we move towards the ICA aneurysms. I will not talk about the exotic and bizarre and exceptional type of the cases. I will talk about very, very simple cases which I have seen in my daily life. And most of these cases are not my cases. I have picked these classical cases from the Maxim Shapiro, from his group, because I want to show you very, very classical cases with the segmental boundaries. So this is the figure. This is my favorite figure. And there are the number of classification about the ICA segments starting from the 1930s up till now. but this is the recent classification. It was developed by the NYU group, again from the Marks and Shapiro group. And it's very simple, it's very practical. So I'll be using this figure throughout the rest of the lecture. So cervical segment, you know all, I'm not going to talk about that again. So we start with the Petrous segment. So this is the Petrous segment. Petrous segment is that segment after the cervical segment when you enter into the base of the skull. So actually, this is the point where most of the dissections and the post-traumatic pseudoaneurysms occur. Otherwise, there is no artery rises from here. There is no branch here. So no true aneurysms are very less likely. Most of the aneurysms are the pseudoaneurysm because, you know, when a vessel enters from the neck into the bone, there is always a pressure change and there is a shear stress. So in case whenever there is some kind of the trauma, so that results in aneurysms. In my, 6 to 7 years practice here, I have never seen any aneurysm arising from the Petrous segment. So Petrous segment, it's vertical and it's horizontal. So you just have to remember this, that this is the Petrous segment. So it's the cervical segment, then the vertical, and then the horizontal. Again, this is vertical and this is the horizontal. So first curve after the bifurcation. I think this is more appropriate. First curve after the bifurcation. And when we come down, first curve after the bifurcation is the Petrous and the second one is Cavernous. That's very simple to remember, I think. So this is the Petrous segment.
इसमें एक से थोड़ा सा वापस जाइए, मैं ऐसी जस्ट ओके. सो जो लेफ्ट लोअर कॉर्नर पे तस्वीर है उस पे ऑल दोज हु आर हियर just think about the answer. What is the first branch coming out that you see, and then what is the second branch coming out that you see? मैं 5 सेकंड देते हैं इनको. 1 2 3 4 5. अच्छा, सबने सोच लिया आंसर. अब डॉक्टर साहब बताएंगे. डॉक्टर साहब, ये दिस इज इंटरेस्टिंग, इस पे लेबल नहीं हुआ है, बता दीजिए इनको कि पहली ब्रांच ये लेफ्ट लोअर वाली तस्वीर में जो डीएसए वाली है,
ये वाली
लेफ्ट लोअर. अच्छा,
ये वाली. अच्छा, तो
लोगों ने जवाब सोच लिया नहीं? लोगों ने जवाब सोच लिया ना. देखिए, अब आप बताएंगे आप लोग सही थे गलत थे. डॉक्टर साहब,
अब ये है कि लास्ट टाइम वी टॉक्ड अबाउट इट अ लॉट, और आज के लेक्चर में भी ये मतलब वी विल रिपीट इट अगेन एंड अगेन. द फर्स्ट ब्रांच आफ्टर द Cavernous segment comes out, which is intradural, is ophthalmic. So this is ophthalmic, okay, and this one is posterior communicating artery. For those who are beginners, it's very easy to remember कि एक साइड के ऊपर ophthalmic होगी और उसके opposite PCOM होगी.
right.
Branches, matlab, there are only 3 branches. The first is the ophthalmic, opposite is the PCOM, and above is the anterior choroidal. Anterior choroidal इसके ऊपर ही बहुत छोटी सी होती है ना, इस तरह की, ठीक है. और यहाँ पे देखो ये चीज खुली होनी चाहिए, यहाँ पे खुली सी कंप्रेस हो रही है.
जी चलिए डॉक्टर साहब आगे.
ठीक है. So I will not spend more time on the Petrous segment aneurysm because I told you these are very rare kind of the aneurysms. This is a very old picture I have obtained from one of the article of the AJNR, and you can see that this is rising from the anterior segment of the Petrous part of the ICA, and it is projecting posterolaterally, so it must be pseudoaneurysm or maybe saccular aneurysm. I don't know the history of the patient, but if any of the aneurysms arises here, the first thing we should think about is this, that it must be post-traumatic or it must be pseudoaneurysm.
True.
Acha, again, the same figure. I'm going to use this again and again. So next, after the Petrous is a very important segment, which is the Cavernous segment. So Cavernous segment is actually, this is the part of the artery which is present within the vein. Cavernous segment, if you try to, visualize this is a vein with the artery and nerves. So here, again, going to these segments after the Petrous, this is cervical and this is 2 vertical and horizontal. This part is Cavernous segment. So Cavernous segment in the AP projection, this is AP projection, it is just like this. It's not so wide, but in the lateral projection, when you see it, it's from the proximal posterior genu to anterior genu. Again, just concentrate on the turns. First turn, posterior genu, second turn, anterior genu, and here it finishes. And from the microsurgical point of the view, it extends from the petrolingual ligament to the proximal dural ring. Now, these two things are never visualized in any cross-sectional imaging or angiographically, but we should know it because proximal dural ring and the distal dural ring, they are very important landmarks, not important for endovascular surgeon, but it is important for a neurosurgeon because you see those rings. I never see those rings. So it extends from the posterior, this is posterior genu to the anterior genu, and it extends from the petrolingual ligament to proximal dural ring. So this, and you have to remember these two curves. So only this part, and it's, so this is one of the figure in which arterial and venous phases are superimposed, just to make you realize that. So this is the venous phase, and this is the posterior part of the cavernous sinus. This is the posterior part of the cavernous sinus, and here is the sphenoparietal sinus going into the cavernous sinus. This is the posterior boundary of the cavernous sinus. And this is the anterior boundary of the cavernous sinus, and here comes the cavernous segment. So,
this is a great picture, actually.
And this is inferior petrosal sinus. This is another one. So, by visualizing, always visualize, because a neurosurgeon can see anything. They can visualize because you see these things in the daily life. So, always visualize that how the internal carotid artery is running into the cavernous sinus. So this is a few words about the cavernous segment aneurysms. Cavernous segment aneurysms are extradural aneurysms. They never bleed until and unless they grow intradurally. So how they present? They always present with a mass effects. Like with a headache, with cranial nerve palsies, and such kind of the compression symptoms, but only and only those cavernous segment aneurysms which grow intradurally, they show you some kind of hemorrhage. Otherwise, they are extracranial and they are extradural. So this point is very important, that the patient always comes to you with the symptoms, compression symptoms, and you need not to rush towards their treatment. This is the point which is very important, because if the patient presents to you only with a symptom of headache, no need to rush. You can wait, you can follow up the cases. I have seen a few of my friends who are overseas, they are following up the cases of the cavernous segment aneurysms for years. At the most, what can happen? If the aneurysm ruptures, what happens? It will transform into the CCF, because in the cavernous sinus, there is also lies the venous plexus, and most of the time when the aneurysm ruptures, it transforms into the CCF. So another point is this, that these aneurysms grow laterally, because on the medial side, they cannot grow medially because of the presence of the bone. So no matter how big they are, usually they are giant size aneurysms, but they grow laterally. So what is this? This is cavernous segment aneurysm. This is proximal and distal, and this is the distal, because I put mark here just to make you realize that this part is supraclinoid. This is beyond the cavernous segment, and this lateral. And this is, this is the point from which the aneurysmal transition. So actually here is the neck. And these are the cavernous aneurysms. Again, and another example. These are again a laterally growing aneurysm, and these are the lateral projections. And you can see that it's arising from the cavernous segment. Here it goes, and it is actually this, from this part, the aneurysmal sac is formed. So here again. So those are the lateral projections, and these are the AP projections. So on the AP projection, it is like this. It can arise from any part, from the proximal part, from the distal part, but you have to identify the intradural extension or it is in the extradural compartment. That's our point. This is very important point. So here is the point. This red arrow is the point where it actually goes, it is transforming into the aneurysmal sac. There, this is the vessel, and here it goes and becomes the aneurysmal sac. Again, here. And by the way, this type of the current in which you can see the whorls within the large cavernous size or any of the large aneurysms, usually we see these kind of the whorl pattern in the cavernous aneurysms. This is called eddy current. Achha. Just to change, again, I put these marks for you, so you tell me, because we are going to talk about these branches a lot in this lecture. So any one of you, I want to know these green arrows, which branches, and these pink arrows, which branches.
But we went through that, right?
Okay. So in the AP projection, it is very difficult to outline the ophthalmic, but this is orbit, so this is ophthalmic, and this is PCOM and this is P2. Achha, next is one point regarding the cavernous aneurysm is this, that very, very rarely they grow medially. But I want to talk about the medial cavernous segment aneurysms also, because these are not aneurysms in which we sit quiet and follow up the patient for years, because classically the patient come to you with the epistaxis. And when the patient is coming to you with the epistaxis, then you go for the treatment, and it's an emergency to treat. So CTA, these are also very helpful. You can see the aneurysmal sac and it's eroding the wall of the sphenoid sinus here. So the CT is mandatory. When the patient comes to you with epistaxis and with the history of any kind of aneurysms, you always see the CT to see the erosion of the wall. And this is a big aneurysm. It is projecting medially, it's eroding the sphenoid sinus, and patient is coming to you with the epistaxis. These are rare, but sometimes you see, I have seen few in my own practice. So in the cavernous segment, lateral and medial, these points are very important. So again, we go back to the same picture. So after the cavernous segment, what is the next? So here is the catch. So when ICA comes out of the proximal ring, which is the last part of the cavernous sinus, it does not enter into the distal dural ring immediately. So that part is called the transitional part, in which neither the ICA is intracavernous nor it is intradural. This small part is called the transitional part, or it is called the clinoidal part. And then there is ophthalmic artery arises, which is obviously it arises the conventional or the classical type of the ophthalmic artery. It arises 1 millimeter distal to the distal dural ring. So this is the first intradural branch. And the next is the hypophyseal segment. This is again a segment which is after the origin of the ophthalmic, before the posterior communicating artery, and here they give rise to the set of the superior hypophyseal arteries. So for the for convenience, all of three segments, they are together, they are called the paraophthalmic. So any of the aneurysm, if they arises, if you want to segregate them in these three segments, well and fine. But if you want to put them together in a one group, paraophthalmic would be fine. By the way, this is very important, because you have to decide between the extra and the intradural component. From the treatment standpoint of the view is very important, because you have to decide. Intradural always presents with a subarachnoid hemorrhage. Extradural, we don't worry. So this is the illustration which I was telling you, that how it looked like. So this is the proximal dural ring. This is the place where we see the anterior clinoid, and this red arrow is the ostium of the ophthalmic artery in the lateral and so this is anterior clinoid, and this is the proximal ring, which is the last part of the cavernous sinus. So it goes from here to the medial ICA wall, and this part is the distal dural ring. It's below, just 1 millimeter to the, and it arises from the roof of the anterior clinoid process, and it goes to again to the medial ICA. So between the purple and the yellow is the segment which is called the clinoid segment, and it is that segment which is the transitional segment which is neither intracavernous nor intradural. And here, this is the distal dural ring, and below the distal dural ring, here is the carotid cave. So this is a very small cave, which is not intradural, but sometimes there is arachnoid membrane recess is here, which makes it, bleed. If there is some kind of the aneurysm is here. So this is the carotid cave, and then it's the ophthalmic artery, which is obviously the intradural. So this, and this is the sphenoid sinus. So just to make you understand that what are these segmental differentiation, we need not to learn all this, but we need to know all this, because carotid cave, anterior clinoid, neurosurgeons see all these things. I have never seen any carotid cave. So I think you are, you will be able to understand now this part. So after talking a long time about this segment, again, I put a mark for you to tell me that which segment is this. It's below the ostium of the ophthalmic artery, but it's after the cavernous segment. So anyone?
Clinoid?
Yes, this is clinoid. Very right. So now we talk about this segmental aneurysms. There are two kinds of aneurysms which arises from the clinoid segment. When they project laterally, they are called the clinoid. But when they project medially, they are called the carotid cave aneurysms. And I showed you the carotid cave, that small pink triangle is the carotid cave. So these are typically the carotid cave aneurysms. And as I told you that they are not above the distal dural ring, but still there is arachnoid membrane going into this, and so they present with a subarachnoid hemorrhage. Again, this is not my case. I take it from one of my teacher. So this is subarachnoid hemorrhage, and this is carotid cave. So when you see carotid cave aneurysm, you need to treat it immediately. This is medially directed, and it is in the clinoid and on the opposite side. If it is laterally, then it is clinoid. And then obviously the clinoid one is not intradural. Carotid cave is intradural. Not intradural, but it may bleed. So again, the same. And this is again medially clinoid directed carotid cave aneurysm. Now I want some of you to tell me about these branches. Now we have talked enough about these branches.
Yes.
Yes. So on the medial side, ophthalmic. Below the ophthalmic, carotid cave. Opposite side, posterior communicating, and above anterior choroidal. Again, to reinforce the same concept, this is unsubtracted and subtracted image. So we go back to our, for the rest of the segment, we go back to our same picture. So after this segment, we have ophthalmic segment. Ophthalmic segment begins with the ophthalmic artery, with the ostium of the ophthalmic artery. So this is the segment, and up to the posterior communicating artery, this. Or there is superior hypophyseal artery, sometimes arises from here, but sometimes we talk about it, sometimes we don't. So this is ophthalmic. So any of the aneurysm which arises from this area is ophthalmic segment aneurysm, and which is obviously intradural. So this is one example. This is my own case. And unfortunately, I do not have the lateral projections, because we have to see the ophthalmic artery in the lateral projection, and I have this. So 3D is always very helpful. Whenever you are going to do the surgery on any case of the aneurysms, always ask the neurointerventionist to give you the 3D. So on the 3D, you can see that this is ophthalmic artery, which is arising from the aneurysmal sac, and here lies another small aneurysm. This is a lenticular striate aneurysm. And here at the AP projection, you can see this aneurysm here, but you cannot, you cannot pick up this aneurysm on this, but it's very beautifully seen here. So again, I mark these vessels for you. This is ophthalmic artery, and this is ophthalmic artery aneurysm, and this is ophthalmic artery. Now, ophthalmic artery, there are variations in the origin of the ophthalmic artery. You should know all the origins. It's infraoptic. It's sometimes it arises from the cavernous sinus. Sometimes it arises above from the ACA. And somehow when we talk about the variations and the origins from the neurological point of the view, then I will tell you those. But the classical type of the ophthalmic artery aneurysms are those which arises from the ophthalmic artery, either from the body or from the proximal end, or sometimes from the ostium. So after the ophthalmic, we have this, yes, we have this hypophyseal segment, which is not outlined here, but because he has put this mark of para-ophthalmic. In the para-ophthalmic, we have clinoid, we have ophthalmic, and we have superior hypophyseal. So superior hypophyseal beyond the ostium of the ophthalmic up to the PCOM. You need not to identify them separately, but you need to understand them for once. So this is the classical example. And you can see that this is the ophthalmic artery. This point I want to highlight here, that is, it is beyond the origin of the ophthalmic artery and supralaterally directed. It is superior hypophyseal artery aneurysm. Again, you can see that this is cavernous, this is transitional segment, and this is hypophyseal segment, beyond, before the PCOM. So this part is the superior hypophyseal artery aneurysm. Again, the 3D of the same aneurysm, and you can see, you can pick it so beautifully that this is ophthalmic artery, this is posterior communicating artery, and this is anterior choroidal artery. And in between the two, we have this aneurysm. So any of the aneurysm which is arising between these two arteries and medially directed and is superior hypophyseal artery aneurysm. And you can see the bleb also, which is the point of the rupture. So always and always see the 3D to find out the true orientation and the vessels to see the vessels arising from the aneurysm.
Dr. Saima, I have a question. What key angiogram findings you use to differentiate antichoroidal and PCOM?
On angiogram?
Yes.
I have a picture of that intracranial and PCOM wala. If you have a picture,
I have the picture also.
Okay.
But I tell you few points that it is very, very important to identify the anterior choroidal aneurysm and posterior communicating artery separately. Because when we deal with the posterior communicating artery, both the neurosurgeons and when we do the coiling, we can sacrifice it if the P1 is adequate, but not in the anterior choroidal artery. And sometimes when the PCOM is hypoplastic, then we need to identify, because we can occlude the anterior choroidal artery, and then that will end up in the massive infarct. So the next is the posterior communicating. So after this segment is over, next is the posterior communicating. Posterior communicating is opposite to the anterior, to the ophthalmic artery. Regarding the posterior communicating artery, I tell you one thing, that posterior communicating artery aneurysm is actually the ICA aneurysm. It arises from the posterolateral wall of the ICA at the origin of the PCOM. So it's not the posterior communicating artery aneurysm, it is actually the ICA aneurysm, always projected posterolaterally. So always and always identify the ophthalmic artery aneurysms in the lateral angiogram. That helps you a lot. So this is typical one. You see, again, I put the marks on the ophthalmic artery, because that gives you the clue that this is ophthalmic artery, opposite this is posterior communicating artery, and here there is an aneurysm and it's posterolaterally directed. So a few points about is this, that we need to identify separately the anterior choroidal and the posterior communicating artery while designing their treatment, and we need to see the P1. If the P1 is adequate, we can close it, and because that can the collateral circulation can go and supply the area from there. So next is the anterior choroidal. Anterior choroidal artery is it's usually angiographically very small. It's not visualized such, but it is always there. You see this smaller one here in the lateral projection. And so this is one of the figure which I have taken also from the Shapiro. And you can see that this is the aneurysm here. It's a contrast retaining sac in the CTA, depicting some kind of the aneurysm which is before the bifurcation, before the terminal or before the bifurcation. So here, again in the lateral projection, this is posterior communicating artery, and above the posterior communicating artery, there is anterior choroidal artery. And most of the anterior choroidal artery aneurysms are postero-inferiorly directed. But direction is not so important. You need to identify. You need to identify the posterior communicating artery first, and then you identify this anterior choroidal artery. You need to see lot of DSA images again and again to develop your eye. So the last part is the terminal segment. Terminal segment is the segment which is extends from the anterior choroidal artery before the bifurcation. Very few perforators are present here, and they are in equilibrium with the A1 and the M1. So just for terminal, just to give the name of the aneurysm, we have developed this part also. So this is a typical example of terminal ICA terminal aneurysm, and you can see this is directed towards the A1 segment. This point A1 segment, this point M1 segment, and this is the bifurcation aneurysm. So this is, you decide the orientation towards the according to the sac. If it is directed laterally, then this is towards the M1, and if it is directed towards A1, then it's, or sometimes you can see the straight. Terminus aneurysms are very common in the younger population, and they are relatively easy to treat endovascularly. This is the 3D and lateral projection of the same, the same. And you cannot see, any precom aneurysm here. You cannot identify here. But again, in the lateral projection, this is terminal IC aneurysm, and this is posterior communicating artery aneurysms. You can see the posterior communicating arising from here. So always and always look lateral and AP projection both, and then come up with any verdict. And in any case, if there is any aneurysm, then always do the 3D angiogram or rotational angiogram to see the branches arising from there. So I would end up my talk here, and this is a beautiful quote from the Pierre Lestunias, because I like him so much. He was not only a doctor, but a scientist. He wrote in the preface of the second edition of the Surgical Neuroangiography the following: anatomy is a language, and mastering this language is essential for physicians involved in the management of patients with the vascular diseases of the central nervous system. So anatomy is important. Pathology comes later. So always and always learn the anatomy. Thank you.